Can I start?
Yes, I think we're ready. Thank you, Lois.
I can start. Okay, thanks. Good afternoon, everyone, and welcome to our session this afternoon, or good morning, depending on which part of the world you are watching from. My name is Lois Chingandu. I'm the Director of External Relations for Frontline AIDS. Today, we have a session that we are presenting. Many of you have seen in the program, the title is HIV and Climate Change, Safeguarding Health in a Changing World. In this session, I have three speakers that are going to speak. And so let me start with my just a few opening remarks. We all know that climate and health are inextricably linked. Frontline AIDS began looking at the intersection of climate change and HIV in 2021. In 2022, we engaged a consultant to support us with a more in-depth exploration of the evidence, the impact on our partners, and what our value add and strengths in this space could be. The evidence of the impact on HIV was overwhelming. Environmental degradation and climate change was shown to have a clear and alarming impact on HIV infection rates, accessing to testing, prevention and treatment services, and human rights. Yet, it was also found that HIV was not being discussed in many of the environment climate resilient spaces. Climate change impacts HIV/AIDS by increasing transmission rates and worsening the health outcomes of people living with HIV. A modeling which was done based on temperature data and data from 400,000 individuals across 25 countries in sub-Saharan Africa, in a business as usual scenario for carbon emissions, showed that between 11.6 to 16 million additional cases of HIV will be realized by 2050 if nothing happens to address the climate change. And an increase in prevalence, shockingly, of 1.4 to 2.1 percentage points. This afternoon, we would like to start by sharing some of the evidence we've uncovered along with the framework that we developed to help us visualize the HIV climate change intersection. And to do that, to introduce this framework and evidence, I have my colleague Alison, who is going to present the framework and evidence layer by layer. Let me take this opportunity to welcome Alison Wilson, who works for Frontline AIDS, to make this presentation. Over to you, Alison.
Thank you, Lois. I'm just going to share my screen as well. Let me just share here. Here we are. So as Lois mentioned, Frontline AIDS has been looking at HIV and climate change for a couple of years. And we've been focused mainly on understanding the evidence around the effects of climate change, specifically on HIV, and on how our partners and the communities we work with are being impacted. What we found is the links between climate and HIV are under-recognised in research and practice, but climate change could be devastating for the HIV epidemic globally. This led us to publish an evidence brief in December last year, and I'm going to present some of the evidence and the framework from that evidence brief to you today. And that demonstrates the effects of the climate crisis on HIV. And within that evidence brief, we also have case studies from community-based partners. The brief and the framework were both informed by conversations with Frontline AIDS partners, funders, and many other individuals interested in the health-climate intersection. And it's underpinned by an extensive literature review. And the framework paints a holistic view based on the evidence of the many ways in which climate change affects the communities most affected by and living with HIV. Before we look at the framework, I just wanted to start with a couple of pieces of evidence that we uncovered in that literature review. The first was the one that was mentioned by Lois in the introduction, where we can see if current trends continue, we could be looking at between 11.8 6 and 16 million additional cases of HIV in sub-Saharan Africa by 2050. And that came from a paper that was published in 2020. And the second piece of evidence there is from a study that demonstrated HIV prevalence rates linked to drought. You can see a single drought in the last 5 years increased HIV prevalence by around 15%, and that's from a paper published in 2022. So what the evidence shows is that while climate change doesn't directly influence the HIV virus itself, climate change can and does increase rates of HIV and negatively affects the health and well-being of people living with or affected by HIV. And on the slide now, we have Frontline Aid's Climate HIV Framework, which we're just going to have a look at now, kind of layer by layer. So at the top, you can see we have the consequences of climate change most relevant to HIV, and these are identified in the literature as weather-related disasters, sea level rise, changes in precipitation and temperature, and air pollution. And it's important to note that these are highly location-specific and could look quite different in different geographies. Next, the evidence shows there are a range of interconnected pathways that lead from the consequences of climate change at the top to the reduced health and rights related to HIV at the bottom. The pathways are interconnected and are quite difficult to separate out, but taken together, they lead to reduced health and rights related to HIV. The first pillar we have is increased human migration, and we're talking there both about the displacement of large numbers of people all at once in the face of a major environmental event or disaster, and also the slow, steady movement of people as temperatures increase, rainfall decreases, and crops fail. Migration can be significant and devastating, affecting livelihoods, support systems, and communities. In sub-Saharan Africa, it's estimated there will be 86 million climate migrants by 2050, and a study in Lesotho found climate migration doubled a young person's odds of acquiring HIV. The second pillar we have is increased prevalence of other diseases, which includes waterborne disease in the case of flooding, also vector-borne diseases, where temperature increase due to climate change means the mosquito that carries malaria is able to survive in new locations, which is projected to include the highlands of Ethiopia, Kenya, Zimbabwe, and South Africa, and also increased zoonotic diseases. And studies in Malawi and Uganda have shown increased HIV viral loads in patients at time of malaria infection. The third pillar is increased food insecurity, and we're looking both at subsistence farmers and also people purchasing food. As crops fail, food gets more expensive and harder to access. This applies to plant and animal crops and also fish, as increased water temperature has a negative effect on fish stocks. Food insecurity has been linked to transactional sex, heightened risk of condomless sex, women's disbarment, poor ERT uptake, adherence, and efficacy, poor immunological and virological responses, higher mortality, and earlier sexual debut. In the fourth pillar, we have increased economic stress. And this applies to the agriculture sector, but also has a knock-on impact across all other sectors. The majority of people living in poverty depends on agriculture and natural resources for survival. And a systematic review looking at the impact of drought on ART adherence found economic and livelihood-related challenges had the strongest impact on non-adherence. We also see increased conflict, terrorism, and ecofascism. And what we're referring to there is a rise in nationalistic and white supremacist sentiment in response to climate change, which in turn causes people to close borders and not share resources. Very often, marginalised communities, including LGBTQI+, and people living with HIV, are blamed and targeted for harassment or violence. And finally, we have the erosion of the health infrastructure, which includes weather-related disasters affecting the physical infrastructure, destroying medical records and disrupting medicines and supply chains, and also health systems being stretched by the increased burden of disease. And these pathways lead to reduced health and rights related to HIV. Climate change doesn't directly influence the HIV virus itself, but it results in changes in the environmental and social systems that impact everything from how HIV infections are transmitted and contracted, to how likely or unlikely people are to live well with HIV, and also the level of age-related deaths. On the left, we have increased rates of HIV. And on the first slide, we had that modelling from 2020 that indicated a potential additional 11.6 to 16 million cases of HIV by 2050 as a result of climate change. This is in part due to reduced access to prevention services, which could be due to the erosion of health infrastructure or the displacement of large numbers of people in the face of a humanitarian crisis who don't have access to services at all. It could also be because individuals with increased economic instability don't have the means to access the services, and that includes everything from PrEP, HIV testing, HPV vaccines, etc. A study in 2009 found after flooding in Namibia, 87% of people with HIV reported disruption to services and 23% reported missing their medication. The evidence also shows increased risk situations as a result of climate-related pathways, and that includes gender-based violence, child marriage, and sex work, all of which are linked to increased rates of HIV. In Malawi, it's been estimated extreme weather has placed 1.6 million girls at risk of becoming a commodity as brides, as their families are unable to feed them due to the climate crisis. And on the right, we also see decreased health and well-being for people living with HIV. And that includes reduced access to ART and mental health services. The effects of climate change and those pathways on the slide above are drivers of stress, which increase the need for mental health services. In environments with increased food insecurity and economic stress, we also see reduced nutritional quality, and that's important as it has an impact on the effectiveness and adherence to ARVs. We also see increased morbidity or mortality from other diseases. And finally, the evidence shows there's increased discrimination and abuse due to HIV status, gender identity and expression, and sexual orientation. Alongside this, the evidence shows there are a couple of amplifiers which exacerbate this cause and effect relationship. The first is the social determinants of health, which are the individual characteristics like sex, level of education, income, etc. There's significant overlap between the communities who have increased vulnerability to the climate crisis and those who face barriers to SRHR services and who are at increased risk of HIV. Social determinants of health compound and magnify outcomes related to both HIV and climate change, so the populations that are most marginalised are also most disproportionately affected. And down at the bottom, the capacity and resilience of the health system and the government response is also important when it comes to climate consequences. For example, if health systems have put in place adaptation measures to counter weather disruption, such as ways to transfer medical records and treatment regimens or backup power, water and staffing plans, the same climate consequences can have vastly different outcomes. The resilience of the health system supply chain is also critical, as well as the government's ability to provide education, temporary housing and other support. You might notice our framework demonstrates only the impact of climate change on HIV and not the reverse. This was a deliberate decision for a couple of reasons. Firstly, in the evidence in the literature, we didn't find any specific evidence quantifying the extent to which HIV could further fuel climate change. We know, broadly speaking, the health sector contributes around 5% of global greenhouse gas emissions, but 65% of that comes from just a few countries. We also know that the people who are most vulnerable to HIV and living with HIV are not significant contributors to climate change, so we focus the framework accordingly. I'll pop a link in the chat as well to the framework and the evidence brief if you want to have a closer look. Thank you. I'll pass back over to Lewis.
Sorry, I was talking, not realizing that I was on silence. Okay, thank you so much, Alison, for that presentation. I forgot to mention at the beginning that if you have any questions, feel free to put your questions in the chat. Someone will be following them, and those questions will be passed on to me to ask. Or if at the end of the presentations, we are hoping that we will have a short amount of time if you want to come on and ask directly your questions. Thank you. So we will move on to our next presenter. We are joined today by Dr. Paskin Ogasanya, from the Executive Director of Alive Medical Services in Uganda, who will speak to us about their experience and the adaptation and interventions they are implementing to address the impacts of climate change on their clients and services. Welcome, Dr. Pasquin. Please take the floor. Thank you.
Thank you, Louise, and thank you, everyone. I'm delighted to be part of this meeting and share the impact of climate change on HIV and AIDS in Uganda. These are our experiences on the direct impact of climate change on our communities and our programs. Next slide, please. Let me start by just giving a brief about Alive Medical Services. So Alive Medical Services is a non-governmental organization established in 2007 as a partner of Frontline AIDS. Alive Medical Services provides community-based, client-centered, and peer-led free comprehensive HIV and AIDS, sexual reproductive health and rights services integrated with non-communicable diseases like mental health, gender-based violence, tuberculosis, as well as economic empowerment. Annually, we serve over 218,000 very vulnerable and marginalized persons in Uganda, in 44 districts in Uganda. Slide 3, please. So talking about the weather-related disasters in Uganda, in the beginning of 2022, we first experienced a prolonged drought. Then around July 2022, there was heavy rains in much of Uganda, causing flooding and the destruction of crops, infrastructure, and in turn also landslides. So this caused loss of lives, homes, property, and income. Slide 4, please. So these weather-related disasters cause people to migrate from places like Karamoja, which is Uganda's driest and poorest regions, to cities like Kampala in search of food and shelter. And as migrants to the city, these communities don't have the social network or economic opportunities they had at home. And they often resort to sleeping outside without access to clean water, food, or health care. So economic stress also leads some client migrants to engage in transactional or commercial sex work. And in this case, it's difficult for them to negotiate condom or safe use to prevent HIV or sexually transmitted infections. Also, unsafe sleeping conditions because they are out leave them at risk of getting malaria. The poor water leads to waterborne diseases. And of course, it leads to overall reduced health and immunity. Also, there will be conflict. There was conflict because the infrastructure in the city is already stretched and not able to cope with the arrival of new people. Certain groups like women and girls and children and the ethnic minorities and the LGBTI persons, they are particularly at risk of HIV. But because of stigma and discrimination and fear of persecution, as you know, the legal situation in the country prevents them from accessing services. Next slide, please. So when there is a climate crisis, there is increased risky situations, and we've seen that firsthand, and there's already reduced access to HIV prevention services. In Uganda, healthcare is mostly paid by the person receiving the medicines. A survey in 2019 showed that 41% of total health spending was out of pocket. But climate migrants already are disadvantaged. They don't have money, they don't have the social network they have or the economic possibilities. So they are not now prioritizing prevention. So this leads to increased risky behaviors, such as having unprotected sex for money during these weather-related disasters, access to services for underlying conditions like including ARVs for people living with HIV or services for non-communicable diseases or mental health is disrupted because health workers are displaced, they have relocated, even resources may not be available, and some places are hard to reach like the mountains. Also, the migrants, because of lack of mobile phones and internet, we are also not able to communicate to them digitally, giving them information and education about the new and increased risks they face. So most of these people are not prioritizing prevention because now they are prioritizing only survival. There was a case of a girl who actually said she would rather get HIV and have food than, prevent HIV and there is no food. Next slide, please. Usually the floods reduce access to mental health services, economic opportunities, food, transport, shelter, and medicines, particularly for those living with HIV, as well as the LGBTQ communities in Uganda. So when there's reduced access to healthcare services, there's increased illness from other diseases as well. And this has led to poor health outcomes, various health problems, opportunistic infections, things like malaria. They can go for treatment, bacterial infections, diarrhea, malnutrition. And this actually happened during the COVID-19 pandemic. This actually even worsened the situation. One woman who was getting her ARVs from our facility because of looking for food, begging for food on the streets. She was injured on the street, and because of that, she could not recover. Also, in the community during this crisis, there's a lot of discrimination against people living with HIV and also the LGBTI persons. And so there's increased mental health, and yet they are not even able to access services, as well as homelessness. So this is in turn led to a vicious circle in which these groups cannot access necessary services, including access to ARVs. There's limited economic opportunities and many others. We've also seen how this climate crisis actually disproportionately impacts people who are marginalized, and like women and children. Next slide, please. So how did we respond as Alive Medical Services? So during this crisis, we were able to work with one of our partners, Duck Foundation, to give cash transfers of $30 per month for 8 months for 2,500 people living with HIV during the worst impacts of droughts, landslides, and floods. So this helped boost the people's ability to buy some food, get transport, and also be able to take their ARVs and other essential needs. So we also provided mental health counseling, mosquito nets, and we were also delivering ARTs to them. What we have seen that is needed is that there's a widespread lack of understanding of climate change and how it impacts health, particularly for populations that are most vulnerable to it. Support measures like economic education, economic empowerment, changing behaviors that damage the environment are really desperately needed. And we've also piloted economic empowerment. And I think we need to also work with governments to educate the community, and so that we can be more informed about climate disasters and what we can do. Thank you.
Thank you
Over
so
back
much.
to you. Yes.
Thank you very much, Dr. Paskin, for that eye-opening presentation. We will go to our next presenter. We are going to hear from our colleague Tanya Disheko, the Director of Programs at Alliance for Public Health Ukraine. We just heard from Dr. Pasquin the result of climate change on the key pathways, which has resulted in increased HIV transmission and reduced health and well-being. for people living with HIV. Ukraine has had a slightly different challenge, but they've also had mass migration as a result of conflict. And we believe there's a lot that we can learn from their experience and lessons learned that could be applied to climate change situations and crises. Tanya, please take the floor. Thank you.
Thank you very much, Louis. A pleasure to be speaking to you today, colleagues. Today is 1,000 days that Ukraine has been withstanding the war that Russia started against us. Next slide, please. It comes as a terrible tragedy. About 20% of our territory is occupied. 10% of healthcare facilities have been either damaged or destroyed. 6 million people have been displaced internally and 8 million have fled to neighboring countries. There was an expectation that this terrible impact will have a devastating effect on HIV epidemics and TB epidemics in Ukraine, but it did not happen. Both HIV and TB are under control in Ukraine. This was thanks to the tremendous effort of civil society and government. On the next slide, I'm sharing some of the results of our work just last year. We continued to find new HIV cases, and about half of all cases that were detected in Ukraine were done by Alliance for Public Health, the organization I work for. Most of them were linked to treatment. Communities, civil society, and government were able to sustain all programs for key populations, not only at the same level, but also increasing them for substitution therapy, for key population prevention programs, as well as being able to innovate, including long-acting agents or bringing in artificial intelligence to help our programming. Critically was to put the person, the Ukrainian, at war in the center of our response. What are some of the learnings from our programs? Next slide, please. Of course, as people have been migrating, it was a major migration within Ukraine, 6 million people. So there were territories which were overpopulated, but also they were territories that were underpopulated. And we used a fleet of mobile vans, which are called mobile treatment points, to help us deliver primary health care to the territories which were close to the front line. Next slide. Basically in those territories, there were not so many people left. Most of them were elderly people, but there were also territories or villages where there were quite a few children still staying during war. Healthcare infrastructure was destroyed there and doctors have left. So actually people were left to themselves to seek health advice to them. Therefore, mobile clinics which could react to the situation in the battlefield, which could respond to the needs of residents in the villages were a great tool to use in such situation of people's movement. Next slide, please. Each mobile van had some basic, had a doctor, family doctor coming, a nurse, as well as some basic equipment, including EKG, X-rays, gene experts. We could do basic checkups for people, and we could include HIV, Hep C, TB screening and support through the clinics. And during the year's time, next slide, we are working in about 200 villages, providing primary healthcare services to about 10,000 people. On the next several slides, you will see several pictures of our work. You see many of our visitors are older people. There are long queues that come to see our clinics. We come to every village about once per month. On the next slide, you can see, the kind of like environment, where our clinics are traveling to along the road. We have trained our doctors for safety. They all use bulletproof vests and helmets, and we are very happy and fortunate that there have not been any casualties. Next slide. It was also very important to support people who were actually moving to the new locations, to the safer locations. In our case, it was the west of the country. So providing some mini grants as a support to communities to help relocate these people was critically important. Those were funding to support, for example, reconstruction of the old house, which became a home to people from frontline territories. Or helping clean the well in this new territory, or helping equip the kitchen, or helping provide some computers to support children's schooling. On next slide, the very important immediate support to people who are migrating was to support shelters. And although there were government and local governments' efforts to provide these shelters, still for our key populations, for people who use drugs, for LGBTQI people, there was often a need to establish separate shelters because sometimes they were not so easily integrated into the mainstream ones. So we've been supporting shelters and safe places for these people. Next slide. And of course, during such crisis, migration, mines, and warfare, there are new groups of vulnerable populations that occur. These are war veterans, and we've been supporting TB testing for the military, and we were linking case detection to treatment. There are people who have, because of explosion of mines, have lost their hands or legs. We have established an habilitation center for them to support their integration and coming back to society after prosthetics. Blinded veterans and blinded civilians during war, another group that needed special attention, and training family doctors to be able to provide efficient care for these people with new health situations, which was very, very important. The next slide shows that actually, apart from migration within the country, it had a substantial migration outside of Ukraine. 8 million people have left Ukraine, and it was so important that the closest countries to us that received most Ukrainians, as well as HIV, TB, substitutional therapy patients, that they would be ready to provide continued support to these groups because they were on treatment and they needed to continuously receive their treatment. In the next several slides, I will share with you how we have established a service. We called it Help Now, which started working from March, almost like 10 days, like a week after the invasion started, which was actually a 24/7 service. Next slide, which was a combination of different parts that the person would be accessing. It was a media messenger, social media messengers, and it was a chat where you could ask where I can continue receiving my ART. I have arrived in Poland. I now need to receive it in Lodz. So we got a database of these addresses, and we were sharing them with people, as well as we established centers in the areas that received most migrants, which help people already on the ground in Poland or in Germany, the countries that received most migrants. Apart from that, there was a continued need for patients to have the connection with their doctors from Ukraine, because often they would not speak the language of the receiving country, and they would not understand their doctor. So we established telemedicine, which united 26 infectionist doctors from Ukraine who continued to provide advice to their patients. There were cases that in one of the receiving countries, the child was prescribed adult ARV regime, and thanks to the consultations from Ukrainian doctors, we could clear it. On the next slide, you can see that we have, within 1 year and a half, we have provided about 40,000 consultations for patients on ARVs, OAT, TB, hepatitis, and other social issues. Nearly each of the consultation had an aspect of mental health and mental support in it. People were in stress, they were disconnected to their close ones, to their homes, they were stressed with the new places, and so each of such consultation had had to account for the mental situation of these people to be able to listen to them and to support them to the hope that is needed. Next slide. Looking on making some of those conversations more automated, more digitalized, we have taken a step further, and we have developed a digital human. It is an artificial intelligence-based technology which we have trained on HIV, TB, and hepatitis, and which started providing consultations in a human-like manner, which is so important. On the next slide, you can see that we have recorded. We have several characters whom we have made videos of, and you can choose the character that you prefer, and then talk to the person on your questions about HIV, Hep C, and TB. Next slide. You can try it yourself. It also has an English version, so you can either access the website twin aph.org.ua II inside, or you can scan the barcode. So concluding, I would like to say that a crisis situation makes you think about new locations. There are people leaving locations, there are people coming to new locations, and we should be prepared to provide mobile services to them, also in a dynamic situation. There are new subpopulations which emerge with their very special needs, like migrants, like also people who have had physical damage as a result of the crisis of movement. Mental health is very important. People are in stress situation, and we should pay special attention to that. And digital assistant can be very handy in situations like this. War in Ukraine comes as a terrible tragedy, but it is also a story of resilience, and some distilled lessons learned can be used in conflict, in migration situations, and in climate change. Together we are strong and we win. Thank you.
Thank you very much, Tatiana, for that very exciting and innovative presentation. There's a lot of innovation in your presentation that I think as communities outside the war zones and dealing with climate crisis and HIV, we can all really learn from, and we can adapt. There's a lot that I see there that can be adapted into other countries and other areas. And I believe a lot of people here will find that presentation really, really beneficial. So that brings us to the end of our presenters. So before we go into the call to action, I just want to quickly summarize the three presentations. We started with Alison, who presented on Frontline AIDS Climate HIV Framework, where there is clear evidence that climate change exacerbates environmental and social vulnerabilities. Dr. Pasquin, in her presentation, outlined how her own organization, AMS in Uganda, are responding to this situation and supporting the needs of marginalized communities. And Tatiana, in her presentation, outlined how her own organization, EPH in Ukraine, have responded to the enormous challenges and disruptions of the invasions. All these two partners are partners of Frontline AIDS that really work at the front line. So we want to end the presentation by just sharing with you our call to actions, because that is the whole purpose of this session. Next slide. We have some key calls to action. This first one is really targeted at donors, and we believe donors can play a critical role in supporting integrated financing efforts that address both climate change and HIV by adopting strategies that recognize the interconnectedness of these challenges. We are already seeing this siloed approach where donors for HIV continue to fund HIV, and new donors for climate change are also creating their own siloed response. And yet on the ground, we know that it is the same populations that get affected by climate change crisis. We are also calling for better coordinated funding and policies. We are calling for strategic alliances between health organizations, climate action groups, governments, and funding bodies so that we can deliver as one body, one package to the communities. And we are also calling for co-financing between, for example, Global Fund and the Global Climate Fund. Next slide. This call is targeted to the national governments. We are calling that national governments must recognize the links between climate change and HIV and strengthen this integration in addressing them through better aligned policies between ministries, supporting community-led health systems, integration with the disaster planning and the national adaptation plans at the national level. Next slide. We are also calling to civil society organizations and community networks to be forceful in advocating for the role of community-led responses across the responses to both HIV and climate change, with a focus on community-led health systems, task shifting for community leaders and community health workers, local peer networks, civil society finance for advocacy, and community preparedness for climate change. Next slide. That brings us to the end of our session. If you have any details or you want to forward questions to any of the speakers that you had speaking today, you can write to Alison. There is her address. I will just quickly check to see if there are any questions in the chat. I don't seem to see any, but if anyone wants to raise one or two questions, please, can you show by hand? I don't see any hands. Alison, do you see any questions?
No, I can't see any questions in the chat and I can't see any raised hands at the moment. In the meantime, I'm just going to drop a link to the evidence brief and the framework that we were speaking about at the beginning, and also to Frontline AIDS Innovation Hub, where we kind of collate some promising and innovative work that happens across the partnership. And within that, we've started looking at climate change as a thematic area. So we've got some examples there of how community-based partners are adapting to climate change. So I'll just drop those links for anyone who's interested.
Thank you. If I think there's something in the chat. It's what you've just dropped.
I think it's just me. Yeah.
Thanks. Right. If there are no questions or comments, I would like to take this opportunity to thank my panelists. Thank you very much for taking the time to make the presentation. And also thank you for the people that managed to attend this session. Please feel free to come back to us if you have any questions. This is work that we are doing. There's a comment for Tatiana in the chat. Thank you very much for that comment. Appreciated. I think this brings us to the end of our session. Please continue the rest of the conference as it continues.
Thank you.
Thank you for your kind words of support. Thank you.